Hi everyone, my name is Zoya and I'm a second-year master's student at U of T at the Department of Laboratory Medicine and Pathobiology. Today I will be presenting my poster looking at immune thrombocytopenia patient sera's ability to mediate the phagocytosis of healthy donor platelets by macrophages. So immune thrombocytopenia, or ITP, it's a complex autoimmune bleeding disorder and it's characterized by a low peripheral blood platelet count. In ITP, the platelet life cycle is cut short by the presence of IgG antiplatelet autoantibodies, which accelerate platelet destruction in an Fc receptor-dependent manner. So although these platelet autoantibodies are driving most of the thrombocytopenia, not all patients have detectable levels of autoantibodies. The technique that's used to detect autoantibodies is a MAPA, which is essentially an ELISA-based assay. The indirect MAPA assesses for free autoantibodies in the plasma, but only detects 10 to 20% of patients to be positive for having these autoantibodies in their plasma. However, previous studies have shown that injecting whole blood or plasma from ITP patients into naive subjects causes over 60% of recipients to develop thrombocytopenia. So there seems to be a bit of a discordance between the low percentage of patients with positive indirect MAPA values and the high percentage of recipients who develop thrombocytopenia after an ITP plasma transfer. The objective for our project was to conduct an in vitro phagocytosis assay using real-world unselected ITP patient serum to determine the ability of patient sera in mediating the phagocytosis of platelets. So as per our methods, we conducted an in vitro phagocytosis assay using a THP1 cell line expressing all human activating Fc receptors. So the THP1 CD16 macrophages have been transfected with FcR3 or CD16 in our lab. These macrophages were seeded into wells and treated with PMA for 24 hours to allow them to differentiate from a suspension cell line into an adherent cell culture. We then collected healthy donor blood and labeled these platelets with CMFDA and opsonized them with either ITP patient sera or a positive control monoclonal antibody. We added the platelet to these macrophages and incubated them at 37 degrees for 1 hour. And after that, we fixed the cells with 4% PFA and stained all non-internalized platelets and imaged using a confocal microscopy. So for our results, we assessed platelet phagocytosis by using CMFDA to label platelets and Elexaflor 647 as an antiplatelet tag to mark non-internalized platelets. So here I have circled a platelet that was internalized, and it's differentiated from non-internalized platelets by the presence of a green fluorescence and the absence of any red fluorescence. Moving on, these are our results for the platelet phagocytosis assay using 10 ITP patient sera. ITP1 has by far shown the highest level of phagocytosis, but ITP4, 11, and 8 also did show positive phagocytosis. Each point is its own experiment with about an N of 5 to 6 experiments per sera. We also use more than one healthy donor for the platelet, so I have point matched each donor to a specific color. For the normal human serum, we also use 2 donors, as you can see by our legend. And the baseline is set as normal human serum plus 2 times its standard deviation, and this is set to determine whether sera is positive or not for phagocytosis. We also determined the involvement of Fc receptors by using specific Fc receptor blocking monoclonal antibodies. So we again use the THP1 CD16 cells, and we used 2 deglycosylated Fc blocking antibodies. We used 10.1, which blocks FcR1, and 3G8, which blocks FcR3. They both showed inhibition to a similar level. Phagocytosis was 100% blocked. As you can see, it's at the baseline with the normal human serum. This could be related to the cell line we use. There could be like possible cooperativity between the receptors. So the findings from our study so far suggest the possible ability to trigger phagocytosis could be greater than the proportion of patients who have autoantibodies present in their serum. Our results so far have also highlighted the involvement of FcR1 and FcR3 in the clearance of platelets, with 1 patient studied so far. Further studies will be conducted to analyze patient sera for autoantibodies using a MAPA. I would like to thank my supervisor, Dr. Alan Lazarus, and the rest of my lab members for their constant support. I would also like to thank our collaborators who provided me with their valuable insight. And finally, I would like to thank Canadian Blood Services for funding this project, as well as our collaborators, U of T, and St. Michael's Hospital. This concludes my presentation. Thank you for listening, and please feel free to reach out to me if you have any questions. I have added my contact information to the poster. Thank you.